and it's definitely afternoon in many African countries. So good afternoon to everybody on the African continent who's joining us today. And I hope your day has been going very well. And many thanks to the Seagull Family Foundation for bringing us together. This certainly is a necessary and important conversation today, especially in the context of the global pandemic. Now, if we have learned anything during this pandemic, is that regardless of geography, of location, or economic advantage, that you're not immune to the shortfalls of a poor healthcare system, which is why it is important to be consistently innovative and forward-thinking in creating and strengthening our indigenous healthcare systems that are both efficient and sustainable, as the theme of today's conference suggests. Now, even before the current COVID-19 global pandemic, health systems across the continent were confronting a number of challenges, from communicable diseases, tropical diseases, AIDS, to Ebola in parts of West Africa and the DRC, and many other challenges that are a result of weak healthcare systems that are not equipped to offer primary and preventive care to its population. Our panelists today, our distinguished panel today, represent a new mindset in healthcare on the continent. They're innovators who are working to bridge that last mile in healthcare while reducing healthcare inequities that have always been known, but now that have been so fully exposed in the last year and a half. So today, in this next hour, our panel will explore ways to build an efficient, a responsive digital health infrastructure that targets those existing gaps in healthcare coverage, and providing solutions and new ways to collect and monitor clinical data so we are ready for the next pandemic if it arises. Let me introduce our panel. Joining us is Dr. John Bwanika. He's the co-founder and director of the Medical Concierge Group. He runs, his company runs healthcare services, the healthcare service known as Rocket Health. And Rocket Health provides a range of services, including a 24/7 telemedicine services. Dr. Bwanika joins us from Kampala. And next is Dr. Yasmine Aguib. Dr. Yasmine is a Deputy Director of Research at the Aswan Heart Center in Egypt. She's an honorary research fellow at the National Heart and Lung Institute, the Imperial College of London. Also joining us from Brooklyn, New York, by way of Guinea-Conakry, is Nasser Diallo, founder and CEO of Clinic+O, which has been working to expand healthcare services to marginalized communities in Guinea-Conakry through a combination of virtual and personal consultations. So welcome to all of you. Looking forward to our conversation in the next 1 hour. I will do less talking from now on, just be asking the questions. And as a scene setter, let's start off by each one of you introducing yourselves and talk to us a little bit about your organization and what inspired you to start the company and the services that you provide. Let's start off with you, Dr. Mark, then we'll go to Yasmine and Nasser.
Thank you, Jackson. So my name is John Mark Bwanika. I'm a medical doctor and e-health specialist. I'm a co-founder and director at a company called Rocket Health, which is a digital health and telemedicine company with headquarters here in Kampala, but it's also registered in Nairobi, Kenya, and also in Nigeria. And what our work is about is we provide an integrated end-to-end healthcare service, which is technology enabled. And if you look back at why we started the work that we're doing, which started way back in 2013, it was on the background that during our training and during our initial years of work, we saw that healthcare remained rather old school in very many ways. In ways people sought information to manage conditions in the time that was spent within the healthcare system while you were seeking healthcare, while seeking consultations, physical consultations, and many things like that. And yet all around us, technology was being taken up in other industries, in mobile banking, in e-commerce, in fintech and the like. And so for us, we saw the opportunity with my other co-founders to be able to develop solutions that leverage technology on one hand to improve quick access to healthcare services, provide it at high quality, but also in a way that is affordable. And so if you look at the work that we do now, it has 5 components, and that's why we call it an end-to-end service. And it brings together the aspects of a 24/7 telehealth center with medical professionals, doctors, that allow people to use basic mobile phones, SMS interactions, and any other chat platforms like WhatsApp to be able to have consultations, from any part of the country at any time of the day, any time of the night. And remember that with inequity in distribution of traditional healthcare services, some people were very far from specialist centers and the like, and this bridges the gap and allows people even from far off places to be able to access consultations. The second component is a licensed lab, and the unique thing about our lab service is that instead of people walking to a lab to get a diagnostic test, we have a team that actually goes out to people's homes, people's workplaces, people's schools to pick a lab sample, bring it back for it to be processed within our lab, and then results are sent to them via email, and then a doctor calls to actually go through these results with a patient. Same for the licensed pharmacy that we operate that provides last mile delivery of pharmaceutical products up to a radius of 50 kilometers from where we are to people's homes, to people's workplaces. However, we also know that certain things may not be able to be resolved remotely. And so we also have a physical clinic where if you need physical assessment, even after the remote assessments that are done initially, we are able to book an appointment for you to be able to come in and see our specialist. And all this is also can be accessed through an e-commerce site. And you can just go to rockethealth.shop and you'll be able to see all these services, be able to do your own booking to see a doctor, book things like vaccinations to be done from your home, buy products for COVID prevention and other items. And so, what we've seen, especially in the last year, is there's been, an augmented focus and growth of our services because of the COVID pandemic. And I'll say more about that shortly.
Thank you very much. Let's go to you, Dr. Yasmine.
Thank you, Jackson, for the introduction to this session. I'm very excited to the next hour, and also thank you, of course, to the whole Seagull Foundation team. So briefly to myself, my name is Yasmine Aguib, and I studied molecular biotechnology and molecular medicine. This is also my specialization, along with a strong commitment since I was at school, actually, that I want, with whatever I will study and train on and learn, to build something and bring something forward at my home country, Egypt. So after studying and doing my PhD in Germany and also working there for a while, I went back to Egypt to work there. Since 2014, I joined the Aswan Heart Center. And what is the Aswan Heart Center? It's a cardiac center offering free of charge medical services, which ranges from complex cardiac surgeries to catheter interventions and other types of clinical service to patients who suffer from severe and complex cardiovascular disease. And the Aswan Heart Center offers this service mainly to the underprivileged or to those who cannot access it geographically for free. We are based in the Upper Egypt, which is an area that doesn't have any cardiac centers or hospitals that could rescue patients that need intermediate intervention. We are also working with other countries, southern neighbors of Egypt within Africa, partnerships with Ethiopia and with other countries where we also get patients referred to us, because at the center we specialize to interventions for newborns actually, or for severe diseases for grown-ups. And when I joined in 2014, my mission and task was actually to build also an integrated research center, a center for research and innovation as a second half of that hospital. So 2008, the hospital started. 2016, we opened a cutting edge research center, because clinical service and medical care is both, is treating patients now and also preparing for the advanced management and being ready to offer the patients of tomorrow the modern and the targeted therapies. So this is actually our mission, and this is what I've been working on in the past years, and hopefully in the coming with lots of enthusiasm.
Thank you very much, Dr. Yasmine. Great work that you do. Nasser, you're on next.
Hi, everyone. Thanks, Jackson. Thanks to everyone for bringing us together, mainly the Seagull Family Foundations. So my name is Nasser Diallo. I'm originally from Guinea-Conakry in West Africa, and have no medical background. My background is more communication and technology. So I used to be a public policy manager for Facebook. I just resigned about a month ago to run Clinic+O full-time after working 2 years at Facebook. Prior to that, I worked with politicians in political campaigns, both in the United States and in France. So I'm the founder and CEO of Clinic+O, which is simply a marketplace that is enabled by technology to bring in medical providers and partners to offer primary care services to marginalized communities in Guinea. Currently, we have 8 million people out of 12 million in Guinea who do not have access to primary care services. And we have 100 million people in West Africa who do not have access to primary care services. Those are our target audience. We are studying in Guinea because it's my home country. I understand the culture and the country better. So Clinic+O is very new. It was established in September 2020 to facilitate healthcare access in Guinea. So we have a hybrid model that is quite similar to that of John Mark's. So we work with community health workers, we train them, and then we provide them technology so they can proactively get immersed within the community and search for primary care cases. And then we connect these community health workers to physicians and nurses remotely through by way of teleconsultation. And we have also what we call home care visits because, you know, technology is not in a certain condition the solution for certain diseases. So why are we doing this? We are doing this because there is a huge gap in terms of integrating healthcare in Guinea, and for that matter, in many countries in West Africa. Healthcare is completely fragmented in the sense that there is no way for the main stakeholders of healthcare to communicate, meaning community health workers, nurses, physicians, lab, pharmacies, and so on. So what we are doing is we are integrating this to make it easier for everyone, both healthcare providers and patients, and for that matter, make it cheaper with the hope that we can cover almost everyone in Guinea and lean on that experience to expand in West Africa in the next 5 to 10 years.
Awesome. Thank you, guys. So just as a housekeeping, we will be taking questions for our panelists. So, you know, get ready to ask them questions. I want to start by asking each one of you to explain a little bit, to expand on this issue. In most African countries, we see a variation between urban and rural areas in terms of access to healthcare. Talk to us about how each one of your organizations are working to bridge that gap, this fragmented healthcare system, as Nasser Diallo referred to. Let's start off with you, Dr. Bwanika. What is Rocket Healthcare doing in that regard?
Thank you, Jackson. And it's been nice to hear what the work that Yasmine and Nasser are doing. It's really, really impressive work. So back to your question, if I start by looking at historically and what happens with the concentration of training institutions for healthcare. If you look at most of the countries in Africa, a lot of the major healthcare training institutions, universities, nursing schools, a lot of them are concentrated within the urban centers or the bigger cities. What that means is that people have already left their places, their villages or local areas to come and spend many years during training in these places. And so a lot of them eventually after school, they've built out their adult lives within urban centers. It becomes extremely hard for them to go back to the rural areas to work. And this is also because a lot of the decent workplaces, a lot of the new age hospitals, specialized hospitals, a lot of the mentors and specialists are also based out of urban centers. An example is here in Uganda. You have the largest concentration of maybe 40 to 50% of the biggest hospitals, of the specialist centers based in one city, which is Kampala. And so what that means is that all these services occupy a small geographical area, and yet the larger population is in the rural parts of the country. And if you see that, for us as the founders of Rocket Health, one thing that we could do is after finishing medical school is that we could have opened up a consultation center, a consultation room, which would see a few people come into our consultation rooms physically to be seen. But we thought, what if we did something better? What if we leverage technology to allow someone, my mother, my grandmother, who lives 200 kilometers from Kampala, from where I stay, to be able to access our services? And so that is the background to the work that we do. So we made it possible that with a call center, just like you would call into any telecom call center, anyone from any part of the country, and you don't need to have any sophisticated things like a high-end smartphone or a mobile application or anything like that. We have channels that are voice call based. We have channels that are USSD based, where you can be able to call in, speak with a doctor, use SMS, interact with a doctor back and forth, get to know what might be ailing you. And what this does is that previously somebody would perhaps take weeks or months just making the decision to seek some form of healthcare service because of the trouble and the hassle of eventually getting to see the doctors. And some people would actually go through their entire lives without ever interacting with a medical professional or specialist. Right now, it's as easy as dialing just a simple short code to be able to speak to a doctor. And what we've seen is that a lot of people, are embracing the service. They're able to use the service. They're able to know things related with as basic as family planning, sexual and reproductive health issues, management of chronic conditions like diabetes, hypertension, even the more recent aspects to do with COVID management and the like.
Thank you, Dr. Bwanika. Yasmine, do you want to talk to us about some of these variations and how your organization is working to bridge that gap?
Yes, very much. So actually, very similar to what John Mark said, Egypt has almost now 110 million people living in the country, but yet the largest, most specialized centers for clinical care are mainly in Cairo, maybe in Alexandria, maybe in one or two other cities, some too, but that's not enough because you have a large country. So actually, when we started, actually with the basing, where is the hospital? We chose Aswan in the south of Egypt because being also in specific matters physically there and moving the workforce and moving the well-trained doctors that usually would be tempted to go to more attractive locations where you also the whole environment for these healthcare workers and doctor, nurses, researchers, everyone, if they are talented and they're strong, they're attracted to specific areas. But here we started a new thing, which is the mission and the passion about what we do is what governs our day-to-day life and not where we are. And afterwards, the next thing was, after placing it in Aswan, was to have a proper strategy of how to choose the patients. We are committing to serving the underprivileged, but we're also committing to serving anyone who needs critical care, regardless of whether he's underprivileged or not, because a soul is a soul. So first help the soul, and then we see all the other matters. And this is why we had to think of a very, of a fair algorithm that helps us select first, of course, by geographical priority. to offer the service to. And then so priority is to Upper Egypt because there are no alternatives, and then how critical the case is. And until now, we've been doing well with this, but of course the waiting lists are huge, and there is more need. So we're building another center in another location, and we started to create also a strategic clinical care service portfolio. So for some cases that are very urgent, that we see often, that we know that we get them several times a week, and they need fast access no matter where they are, we started to develop prioritized programs with even cars coming in specific roads to have those, for example, newborn babies that are sometimes called blue babies because they have switches in their cardiovascular system, and if you do a surgery within 24 hours, you can rescue their lives. If not, then they don't survive. So you need to get those people, those babies very fast to wherever you are. And in that case, we are sometimes remote to the population mass. So it needs a lot of adapting to the needs, assessing the needs of the the regional environment that you are in, and then expanding and regularly rethinking it, how to optimize, improve access, and develop the programs. So these are just some examples of how we try to act against the decentralization of services in a country like ours.
Mm. Thank you very much, Yasmine. Nasser, you want to come in here?
Absolutely. Thank you so much. So actually, I want to start by saying the very assumption by which healthcare was designed in our country, Guinea, are no longer valid. You know why? Because it is based on a paradigm that is that we have to wait for someone to be in critical condition to receive care, right? So in countries that have limited resources, as my peers pointed out, it is very difficult to wait for people to get sick and in critical condition to provide primary care, especially in rural areas where you have very limited resources. Our approach has been extremely radical in the sense that we want to invest in prevention, right? Because the earlier we detect these conditions, the better it is for everyone in terms of finding proper care. Those of us who have had a chance to live in developed countries, we are aware that healthcare is relationship management, right? There are very few people who have had a chance to have heart surgeries or complicated healthcare. It's just a psychological thing. It's not to say that the work of doctors is not very important, but there are very, 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 very good things and great things that we can do to improve people's health and well-being. And what I mean by well-being here is the reason for which people wish to live, right? So often we tell people, hey, you have this kind of diseases, and then you give them a treatment, and then so what? Someone is healthy, they have nothing to eat, they have no job. How someone can be healthy with those conditions? So we are going beyond of health. We are telling people what to eat, what to drink, how to, all the things that are related to the determinant of health, because we have no healthcare facility within an area of 100 kilometers, and we do not have the resources to build one. But we want to encourage people to use what they have, the technology that we are building to connect people remotely. But our main goal is to tell people we look like we are healthy today, and healthy people get sick. So it is important to do your checkup when you are healthy, and which is not a tradition in our countries. It is important for you to watch your weight, right? There are some things. I'm not singling out anyone, but there are a lot of corporations in our continent that are selling unhealthy things that are really, really killing our people. And we are all sitting there consuming these things. And whereas we can inform our communities because we have had the chance to know better. So that's what we are doing in rural Guinea. And in terms of public policy, we are also communicating with the government to tell them, we are not asking you to build hospitals or to build sophisticated clinics here, but we want you to help us to bring connectivity in this part of the world, right? Because John Mark may agree with me, there is no telehealth if you do not have, or remote consultation if you do not have connectivity. With that matter, we are working with mobile network operators in our home countries who are willing, to build towers wherever we suggest that there is a high risk area of healthcare to those local communities. So it's a partnership, but prevention is a huge component of what we are doing, in addition to providing primary care services to those who are least well off.
I like that holistic approach. I like the idea of also incorporating education on your diet and things of that nature as part of your mission, because again, health is not just about going to the hospital, waiting to be sick to go to the hospital to seek for healthcare. Let me turn to Dr. Bwanika in Uganda. Using your organization as an example, how do you navigate these issues related to the digital divide, as Nasser Diallo alluded to? If they have an issue of connectivity in one area, they're able to tell the internet providers to build some infrastructure in that area. Talk to us a little bit about how you're able to bridge this digital divide, since most of the people in your area of coverage most likely don't have access to internet or internet services.
Yeah. Thank you, Jackson. So one thing is for sure that over the last decade, the government of Uganda and other governments where we expand in Kenya and other countries in East Africa have done quite a good job in trying to expand connectivity in different parts of the country. And this is largely because they recognize the value that technology is going to play in the overall economic stimulation for the countries, but also because these countries are largely depend on tourism as a source of revenue, and tourist places are very much also in rural places. There's been that drive to make sure that there's connectivity in these places because tourists need that connectivity when they travel and things like that. So along those lines of development and infrastructure development, there's been also of course, the collateral value to us who are providers of healthcare to be able to leverage that, to be able to reach more people. However, like I mentioned earlier, one of the things that we've been keen on as a company is to try and leverage existing platforms that people have that are ubiquitous and are used on a day-to-day basis before we introduce more fancy technology platforms. So instead of building a mobile app or chatbots right from the onset, what we decided to do is that we shall just have a toll-free line and USSD platforms that a lot of people have access to, because the cost of a mobile phone has gone down considerably, and a lot of people in almost every family can be able to access a basic feature phone, which is even like $10 to $15. And so you don't need to have high-end broadband connectivity to be able to access our services. So we're saying that from the basic voice call, SMS, USSD, you're able to use. Of course, the growth overall on the content in the use of mobile wallets and mobile money means that there's not too much, the learning curve for our platforms is not that high, because people are already using these platforms to transact. And if you know, East Africa, Kenya, Uganda lead in the use of mobile money services across the world. And so we just leveraging what people are already using daily. And so that is something that helps us to tap into communities, even where a lot of the sophisticated aspects of technology have not diffused a lot. The other thing is also to allow for platforms or for mechanisms whereby people can use the service on behalf of the others. So for example, we have a lot of people who access our healthcare services on behalf of other people. So for example, if you're a mother, you can consult on behalf of your child who may not have a phone, because we know that Africa is a largely young population, so a lot of people are below 15 years. So we don't expect these people to have these platforms to be able to access the service, but their parents can. Their older siblings can consult on behalf of on behalf of them. You have the older folks who may not be able to navigate these technology platforms easily. We also made it possible that we can create ways where you can have, even if you have one mobile phone, a basic mobile phone within a home, they can be able to consult on behalf of someone else, and we create a unique record for those people. So that way we navigating the challenges of connectivity that are happening, but also, of course, we continue to engage with the government, with the regulators, with mobile network operators to be able to increase these things so that we are able to provide higher quality services, video-based services, and things like that. But these things come with time, and we think that we are in a good place right now.
Now, just as a follow-up, what happens if, for example, a patient does not understand the terminologies used in the prognosis? Is there an inbuilt functionality in the platforms to translate for them in the language they understand?
Yeah. So what happens for us is that because they're interacting directly with the healthcare professionals, what we do on our side is right from the hiring process, we try to get a good mix of professionals on one hand that are able to speak the diverse languages that cover the majority of the populations in the countries that we work. So that means that you will be able to explain to somebody in their local languages using terminology that they actually understand. The other thing is that we know that this kind of healthcare delivery model is very new even to the health workers that do it. This is not how we were trained to deliver healthcare in our medical schools. And so what we've done is that we've created a training program using professionals from telecom companies and other sectors that have been doing this kind of delivery model for many years, to be able to come and continually train and improve the delivery skills of the medical professionals, so that we are able to learn how to break down complex medical jargon and terminologies in a way that actually makes this content understandable. But also overall, our team is very diverse. It's not just medical professionals. It's a team that has also communications and marketing professionals that work with us to say that if you're working on content that is going to go to these communities, if you have a team of medical professionals that create this content, you also have a team of communication specialists that review it and package it for the last mile consumer facing versions that are easy to understand for everyone. The idea is that you want
target market. Yeah. They tailor the content to the target market.
Exactly. So the idea is that you want my grandmother, you want that old lady on the village that you were born to be able to understand a condition, to understand malaria diagnosis, a diabetes diagnosis, the same way you as a doctor would understand it. And so that's the goal.
Dr. Yasmine, let me ask you actually, and then I think this everybody should be able to chime in on this one. I mean, it's the elephant in the room. We have to address COVID and the pandemic. And my question to you is, how did COVID change how you conduct business, and what opportunities has it provided to you in terms of learning about your community's health needs?
Yes, I mean, that's we're still learning, because we have all these waves and ups and downs and things that might have worked a few months ago, depending on the people's psyche and the patient's need change with every wave. But it was a major change, because suddenly you had both the caregivers or the clinical service providers and the patient side both always weighing what is more important. Is the pain that I have or what I'm suffering from more important, or is risking getting infected on the way to a service or while visiting a doctor? It was always this dilemma. Also with the clinical service provider, should I call in a patient that I know has applied and needs a surgery within the next 3 weeks now, or should I wait until things get better and there is no risk of infection? And then it was actually summarized for us in a question like, okay, what is worth, to die due to or to a COVID infection, or to die due to an aortic dissection that needs immediate treatment? Well, both, the end outcome is the same. So it was a matter of weighing risks, and same for the patient. So it needed actually a lot of awareness on the patient side. And there were actually studies that came out and said, well, during COVID, a large reason for mortalities was not only COVID itself, but also because patients suffering from other problems did not access the clinical care they needed, so they passed away. So the number of deaths also rise. And then, so we decided to find a way to operate by under the best possible circumstance that help us protect the patient and their families and as much as possible. And we had, within a very short matter of time, to develop a way of testing, while it was still not clear which tests are to be trusted, fake testing, expensive kits, accessibility to kits, because the companies producing them were prioritizing the produced batch. Where should it be shipped to? Should it be shipped within the country of production, or another country like us in Egypt, which is far away? There was sort of access to everything, to all these possibilities. And I think it was very important that at that time to have all the different expertise meeting regularly. So every day, to assess situation and find creative solutions. And I can speak, for example, about everyone now knows that the position and the image of biomedical research changed completely during the past year, because we knew that biomedical and clinical research was a matter of decades. Yes, you have the idea, then you design the studies, then you validate, then you go into clinical phase 1 and 2 and 3, until this work is translated into actual medical service or medical products. And suddenly it was not like that. The researchers, who were actually a bit separated, suddenly were sitting, and because they had the training to work with data that were coming in raw and validate them and understand them and move to the next action point, were the ones who were giving the information and data to assess the hospital's strategy. Lots of work was being done online to plan all this and to be able to continue to operate. So I think it was just a phase, and it is a phase that brought all disciplines closer to each other and made everyone work solution oriented in the now, not in the after 5 years or 10 years after approval of ideas, but now let's translate what we know into action, into policies, and into maybe products, right? So it was an amazing experience. It still is. It of course has its I say amazing because it fueled up the energy and the field, and it made people realize what they can do in a short time and not in a longer. And this is how the young generations operate. They are much faster, and they can react in that way. Everything is getting faster. Sometimes we suffer from that, but in that case, I think the speed was also important and is promising for the future.
Mm-hmm. Thank you, Dr. Yasmine. Nasser, do you want to address on how COVID has changed how you conduct business? I know your organization is still kind of in infancy in many ways, but I'm sure there's so many things that you have learned during this time of the pandemic, and how that has affected your relationship with the community.
Yes, COVID has shown us two things. One, the limit of global health, and the flaws of even developed countries in terms of healthcare. We are a country where Guinea is a country where we tend to think that we can get help from everyone. I'm not very proud of that, because we have our own resources and we can plot our own solutions. So what COVID has taught us, it's when everyone's houses are on fire, no one can help you, and you're left on your own, right? So the second thing, it just revealed to the world what some countries are going through. To us in Guinea, COVID is nothing new, because we have known worse, such as Ebola, Lassa fever, right? Those are pandemics that are as deadly as COVID, and we have been dealing with them for a very long time. Unfortunately, we have not learned great lessons from them. Now that we could not turn to anyone who could help us, right? We just realized, wait a minute, we have to do this on our own. And that's where public policy started kicking in. Connectivity started, policymakers started thinking about, what can we do if we are on our own? How can we take care of our healthcare system? Think about our hospitals that are really not appropriate, meaning public hospitals that are not really appropriate for people with low immune system. And as Dr. Yasmine pointed out, these people come here with preconditions and very limited sanitations. It was just a tragedy. What we have learned at Clinic+O is we have to do two things when providing primary care services. We have to think about protecting patients, but also think about protecting the providers, right? So what that means, when we started doing telemedicine in Guinea, both providers and patients were reluctant. How can you provide healthcare over the phone, right? So once they realized, like, this is the best approach and the best option for both the providers and the patients, they started listening to us. We have 0.08 physician per 1,000 people in Guinea. Now, if you put these people in danger through a pandemic and they die, what you're gonna do next? That's how they started opening their eyes and realizing, wait a minute, I'd rather take this consultation over the phone virtually, so someone else can have a chance to see that doctor, because there is nothing else to protect this doctor if they get infected with COVID. We are in a pandemic moment and doctors are not immune to COVID. That's the first thing. And the second thing, it is prioritizing and figuring out what are the resources that we have based on the conditions and the circumstances in which we are in. And that was also very, very, very difficult because we have limited resources. Some people felt left out, some people felt abandoned, but since the resources were very limited, sadly, we had to watch people go through difficult conditions. And I hope this has been a lesson for us in terms of prevention, in terms of increasing our capacity, and in terms of ensuring that this is not going to be the first global pandemic. And unfortunately, it won't be the last global or regional pandemic. So we have to get ourselves ready. We have to get ourselves prepared as African countries, as African nations who have resources. We cannot just say we are a country if all you do is medical tourism, for God's sake. You have to. And
the African continent loses billions of dollars in medical tourism each year. But Nasser, real quick, you know, it's still on the issue of, on the question of lessons. I know Guinea went through a health crisis a couple of years ago with Ebola. What are some of the lessons learned from that time that you see your country using right now to deal with this pandemic?
To be honest, the way the Ebola was dealt with in Guinea was not the most efficient way, because we had the attention of the world, right? At the time, Guinea was the center of the attention. And unfortunately, we did not make the most out of these resources, meaning in terms of increasing our learning capacities, improving our healthcare delivery, right? Expanding access and quality of care to marginalized communities. What was done positively was to increase access on the regions that were affected by Ebola. That was something positive, to a point where we have enough healthcare workers within regions, because it was not the whole country that was affected. Yet there are other portions of the countries that has nothing. So distribution and equity is still a challenge. But what we are doing to help the government, because government cannot be the solution of everything, is to tell them, wait a minute, we can implement this process using different resources or using technology to get the same result here. And we have been very fortunate that the government has been a great collaborator, a great listener, and then they are involving the private sector, because we know healthcare is a matter of public-private partnership. And when that public-private partnership is strong, everyone wins, and the cost of healthcare goes down and the quality of healthcare goes up.
Dr. Bwanika, real quick, I wanted to, I know as much as there are so many advantages to using remote technology, there's got to be some sort of shortfalls in this or downside in the proliferation of digital health care services. Can you talk to us about some of that?
Yes, so some of the things, of course, that we know could become a problem is increasing the divide in access if there is a technology access divide in itself. So when we started out a couple of years ago, more than eight years ago, we could see that the utilization on our platforms was predominantly male users. It was about 70% males and about 30% females. And we knew that because also that was going along the lines of the adoption of technology. And so that could be a problem in some places. However, what we've seen over time, at least here in Uganda, where a lot of our operations are centered, is that that has changed over time. And what that has done is that we now see about 45% females and 55% males. And that also is in line with the growth and adoption of mobile technologies, even with certain circles that previously did not have access. And so that's one of the things that could be a problem, but we think that the overall population adoption is helping to even that out. But I also know that some parts of Africa may not exactly be following those kinds of trends, and so that could actually be a problem.
Right. And before you go, real quick, I wanted to ask you, how do you convince these ministries of health in our countries, many of them headed by, I guess, older populations, you would say, not easy to adapt to change, to embrace these new digital health technologies and solutions? How do you sell this to them?
Yeah, so of course it's not easy and it takes time. And indeed, when we're starting out, a lot of people considered our work more like child's play, more like a hobby that is going to go away. But I think over time, because a lot of healthcare in Africa is largely funded by development agencies like USAID, like DFID, and other entities from outside. And these are entities that come from places where some of these technologies are being deployed to a large extent to improve delivery of healthcare. And so if you look at the development and strategies for the countries, they are also now forced to include and adopt digital platforms even in the African countries. And so what that does is that it also helps them see the value. But also the idea is to continually create enough evidence that is disseminated within these circles in ways that they understand, that helps them. So what we do, what our team does is that for every work that we do, be it with a research organization, be it as part of a large public health project, if it's work with the private health insurers, every evidence that we show about the feasibility of using technology for, let's say, dissemination of HIV self-testing kits, for improving men's involvement in healthcare services, for improving family planning and maternal and child health issues, we make sure that we organize dissemination meetings or take part in conferences where these results are actually disseminated and shared with these policymakers, so that they see the evidence with their own eyes, so that next time you lobbying for the funding and financing of digital health solutions within the budget, they know why it's important. And so we know that this takes time, and sometimes there might be even much more evidence than the movement on the policy side. But over time, these people are, also appreciate these efforts. They appreciate the value, the impact, and eventually they come on board.
Mm-hmm. Dr. Yasmine, I wanted you to bring you in as a researcher. This is a very important topic. They say that one of the biggest issues on the continent is the lack of research. And, you know, we know that most of the research that is done in healthcare is done, you know, either with Western funding and done in Western labs and Western universities. How is that lack of research and development impeding your work as an African healthcare person who is also involved in research itself?
Yeah, that's a very important thing because it is indeed research. Biomedical research is an investment. It is expensive. It requires expertise and funds. And when I was planning always to go back to Egypt for work, everybody was telling me, if you want to stay a translational researcher, well, you should not go back to Egypt and to Africa and stay in other countries who can afford that. But and then when I'm working now, it's actually a very critical thing because we offer free of charge medical service, and all our funding comes from donations. So the question is to invest or to spend the donations in immediate service, or to invest part of it in the research, which means in the future. And it makes us as researchers very aware of every penny we spend. It's expensive research. And we know that instead of performing this work, we can also, the money can be spent for a specific amount of surgeries or a specific amount of lab interventions and all that. So this made us think very well about the strategy. And I'm talking from a small center's perspective, but it can be translated into in larger scales, which is we need to look at the need, the largest need, and to design the research to serve that need. So we look at the diseases that are highly prevalent in the population or on the continent. We look at diseases that are rare, but in our cultures, because of consanguinity and intermarrying amongst relatives, they come in very high doses and very fatal because of the genetic density of the variants that cause them. And we design a program that way, with an eye on how this can be translated into tools that, instead of having growing waiting lists of patients that might die if they miss a surgery, in the future we will have data and information to prevent the disease from developing that way. So, and it needed a lot of work with also funding schemes and budgeting concepts that are out of the box to be able to design these studies that will help the patients. Because the thing is, medicine, we know that every mobile phone that we have gets outdated after a while, and everyone we see also, even all countries, even with limited budgets and suffering economies, know that this about all the mobile and computer service and all that. But also the way we are treated gets outdated. And if we do not collect data, and if we do not understand our bodies in our populations, because each body is different, then we will stay with the outdated medicine or medication strategies in 2 and 5 and 10 years. And we don't want that. And the future of medicine is understanding the data of our bodies. And as Nasser said, it's a holistic concept. It's not only what I suffer from now, the pain. It's not only the genes, it's the proteins, the epigenetics of the body, the environment, what we eat. And all this is being translated into data everywhere in the world now. And these data will help every one of us access targeted modern therapies, like in cancer. Instead of radiotherapy or chemotherapy, for specific cancers, we can now get a targeted pill. To get that pill, you have to go through a diagnostic procedure that is often expensive to understand if the cancer one has a specific cellular profile and molecular profile. So this is where we want to generalize this type of treatment everywhere, and not have differences worldwide of who can access targeted modern therapies and who cannot. Right. So we need to work on data collection, and we have to have generations that have the medical, biological knowledge, but also data scientists, and build infrastructures like where we store our data, own them, and understand them.
All right, so we have only like 5 minutes to go, and I just realized that we do have lots of questions that came in. We might not be able to get to all of them. Actually, we won't be able to get all of them, and hopefully I will share them with you so you can answer them offline to our listeners. I know the Future Summit is still ongoing, and so you'll have an opportunity to answer them for those who still be following this. But I want to thank all of you for sharing these great insights about your work and the future of healthcare on the continent. Let me just get one question from a Dennis Mwanguzi. I'm going to ask this to Dr. Bwanika, and you probably will be the one letting us out here, because just make it as short as possible. The question is that one of the major obstacles to providing healthcare or quality healthcare and achieving universal health coverage is the management of the patient journey. And he says that digital health is very key here. So how do we improve patient journey management?
Yeah, thank you, Jackson. So when we think about someone trying to seek health services in a lot of the African countries, it's more like you get a pain somewhere in your arm, and you wait it out for a couple of days, and you're trying to make that decision: should I go to hospital, should I not? Then you get into a taxi, you spend 2 hours or 3 hours, get into a hospital, wait for another 3 hours to be seen by a doctor, and then wait another 3 hours, let's say, at the lab section, and then wait to see the doctor again, and then wait for medicines. And that's if you're lucky that these things are all happening in one place. A lot of the times, where the doctor is not where the lab is, it's not where the pharmacy is. So just getting more like a diagnosis for a symptom that you've had might take maybe 2 to 3 days. And so you can see how much time, how much loss of productivity can be encountered in this. And then contrast that with any platform like Clinic+O for Nasser, our own platform, whereby just by being able to call from the comfort of your home at a cost which is a fraction, 20% or 30% of what you'd take, and even in less time, you're able to talk to a doctor, talk to a pharmacist, talk to another health professional, and get to make that decision on whether this is something serious that needs you to go to an emergency room, or this is something that can actually be managed at home and shouldn't worry you, or this is something that can wait and you go see a doctor in a week or so. And so if you use that example, you can see how making healthcare access through these platforms can improve not only the time within which people are able to get the service, but also save them a lot of money, make sure that their productivity is not lost, because all that time you would spend trying to get to see a doctor, you now can go and work, spend time with your relatives, spend time with your family, spend time in school, and the like. So if you sum up all this work that the panelists have been presenting, Yasmine, myself, and Nasser, it is how technology is trying to bridge that gap and bring the person who needs a healthcare service closer to the person providing it, and removing any barriers that make this a complicated process, and make it as easy as either using a basic SMS, a voice platform that you've always used to call your people, or a mobile application on your phone, or know where to take somebody for a cardiac assessment because you know where it's located, because they've provided information on what kind of care they provide and what you're going to pay or not to pay, and things like that. So for me, that's a simple illustration on how digital platforms can improve the patient journeys in Africa.
Okay, we have only 2 minutes. I want to ask you, Nasser Diallo, last question, 30 seconds. What are some of the things that funding and funders need to remember as we talk about healthcare in the post-COVID world? That's a question coming in from our audience. 30 seconds, we have only 1 minute to go. Your mic.
Thank you, Jackson. I think funding and funders must understand that healthcare providing funding is extremely important, but we have to listen to the experts. And what I mean by the expert here is the patients. right? So the fact that you're providing funding or providing support does not mean that you know the solution that work in communities that you have never been, right? Just imposing things, and many funders do, some funders do, many funders don't, right? It's not helpful. And also we have to, as John Mark and Yasmine pointed out, you have to take responsibility. You talked about the question of research. We have to tell our government to support us in these things. I cannot come every day in your house, Jackson, asking for food and hoping that I will be fed all the time. So we have to take responsibility. We have to ensure that people understand local context, which is extremely important. And finally, we have to collaborate within organizations. So for example, mine, Yasmine, and John, so we can leverage on the resources that we do have, and then do things more positively, because there are some learning curves that I don't have to go through because John or Yasmine have gone through them, and that can be spared to me. And each of these people is in a different location: East Africa, North Africa, and West Africa.
Collaboration. Guys, I want to thank you. We just ended over about 1 minute. Hopefully we are still live on air, but I want to thank you very much for sharing your insights. Nasser, Yasmine, Bwanika, much appreciated, and much appreciation to the Sigo Family Foundation for organizing this very much needed conversation. Goodbye, everyone.
Bye. Thank you so much.
Good night.
Bye-bye.
Bye.
Bye.